point that Dan already made, that this is really a team approach. And that's how we look at these patients, that this is a multidisciplinary team that's looking after the patient, where really all these specialties, radiation oncology, surgery, medical oncology, and pulmonary medicine actually come together and take care of an individual from the beginning, where we plan the therapy, and in the context of planning therapy, trying to minimize the amount of radiation exposure to the lung that's not affected by the disease, or the lung itself, and then really focusing the radiation to the surface of the lung where the tumor is, using a strategy called IMRT. Is really something that you're doing up front to try to prevent these complications like radiation pneumonitis. But when we encounter it, it's an inflammatory response caused by the ionizing radiation that we then treat with anti-inflammatory agents.
I just want to comment that it's important to distinguish between radiation pneumonitis and radiation fibrosis. Radiation fibrosis is the scarring, which is often the result of radiation-induced pneumonitis that may have been treated or may not have been treated. The important differentiation is that the medications that Tobias was mentioning, the anti-inflammatories, often have their own toxicities. So prednisone and other steroids can be toxic when taken for long periods of time. Many of you who are patients in the audience have been on these drugs, and there are side effects. And if you're giving that for someone with radiation fibrosis, with fixed scarring in the lung, there is really no benefit and just harm. So it's very important to distinguish between whether there's active inflammation in the lung that would benefit from steroids and fixed scarring that's not going to benefit. And there are also some other side effects of radiation that we do see. We actually see pleural effusions on occasion, and it's really important from a prognostic perspective. We were just talking about pleural effusions on the side of the remaining lung. If you've had radiation, it's not uncommon you get a small pleural effusion and you drain it and there are no tumor cells in it. And that is just from radiation injury to the pleura itself and not indicative of a progression of the disease. So very important to distinguish. And then we're often seeing, I can't say often, but we're occasionally seeing some patients with heart problems that from radiation therapy and the complications that may arise from that, especially the pericardium, which can become stiff and limits heart function. And sometimes pleural effusions occur because the pericardium becomes stiff and scarred from the radiation therapy. So I think it's important to remember that radiation therapy is quite beneficial for a lot of our patients, and relatively few of them have serious complications. But I think as pulmonologists, we have to be aware and help our colleagues in radiation oncology in terms of managing these patients.
So I often hear from patients, or I suggest quite often that they go for pulmonary rehab. Can you talk a little bit about what pulmonary rehab means and how often you refer patients, or the type of patients you think will benefit from pulmonary rehab?
Yeah, and I think that's a very common question. Pulmonary rehab as a program is actually very similar to cardiac rehab, which is a structured exercise program where people actually get monitored and actually get taught pretty much aerobic exercise regimens, as well as some breathing techniques. So these programs run for 6 to 8 weeks and are pretty much designed to introduce patients to a regular exercise schedule and make them actually comfortable exercising, with the goal to exercise on their own. And I really liked the comment that one of the previous panelists made, actually Dr. Sugarbaker, regarding that this is kind of a athletic event going through these types of therapies. And I'm actually personally not necessarily focused on sending people to pulmonary rehab or cardiac rehab. I think the patients need to do what they're comfortable with. Everybody needs to understand that maintaining your health and maintaining physical activity through these very difficult treatments is actually very important for a good outcome. It actually raises your spirits. It kind of keeps you sane as you're going through all these treatments. And it also, I think, in my mind, has a positive effect on the immune system, on everything else in your body. And trying to figure out the best way to do that, I think it's very important. And if in that context, pulmonary rehab is helpful, I certainly am happy to refer people to pulmonary rehab in this context.
I would say we've underutilized pulmonary rehabilitation, and maybe we're babying our patients a little bit, but I fully agree with what Tobias said. It's extremely helpful. It's non-toxic. It's generally reimbursed by insurance companies, and it can be extremely helpful. The other part of it is that it's often sort of group therapy. So when you go to pulmonary rehab, there are often other people going through the same process. Maybe not all who are recovering from surgery or treatment for mesothelioma, but all who have some impairment in lung function. And there's some benefit to supporting each other during that process. So my patients who have gone through pulmonary rehab enjoy it. Part of it is gets them out of the house, and doing something and being active and being part of a community.
And maybe giving a little bit of a control back to a patient.
It's actually, and we are trying to expand this into mesothelioma. We actually have a very active program at our institution that's actually focusing on the rehab aspect, but then also of self-empowerment of patients, where you actually kind of take control of your disease and you actually actively are involved in the care, but also actively are involved in doing things in your activity during your daily life and activity of daily living. And that's actually been very helpful for other patient groups already. So we hope that this will also translate into help in the mesothelioma community. But for instance, the chronic obstructive pulmonary disease, it's actually been very helpful beyond just the physical exercise part of this.
And I'm also wondering, cough, chronic cough seems to be such a complaint in this community. Tricks of the trade, first of all, what is chronic cough? What is the cough? What are the underlying causes of the cough? And then maybe what are some of the remedies that are used? And I know I'm asking, it's a wide open, I know there's a lot of different reasons, but if you can go into some of the basics of what the most common causes of cough in a mesothelioma patient.
You have to understand that I think it's easier to treat mesothelioma than it is to treat chronic cough. Chronic cough is the